Okay, our next presenter is Dr. Dupré. Yes.
Okay, so this has been a team effort on the part of Dr. Tyler Ellis, who's in the front row, as well as two students in the second row, Madeline and Felicia, and then also Johnny Newton. So I'm excited to present to you all some of the work that we've been talking about for the last year. I'll start this off with giving a brief background on colorectal cancer epidemiology. I'll be straightforward that I'm by training a breast cancer epidemiologist, so I might be directing some colorectal cancer questions to my colleague, Dr. Tyler Ellis. We had three aims as part of this pilot project grant that were essentially to identify cancer hotspots in Kentucky. I'm going to mainly be focusing on colorectal cancer for this talk, but we also did this for breast cancer in Kentucky. And then our second and third aims were to try to describe the area-based lifestyle and socioeconomic correlates, as well as environmental correlates of residing in these cancer hotspots. And then I'll end off talking about some future potential directions that we have been talking about. So colorectal cancer is one of the most common cancers diagnosed in the United States and worldwide. On the top area of this slide, we have the estimated number of new cases of cancer in the United States each year. So colorectal cancer will be diagnosed in about 80,000 men and about 70,000 women each year, accounting for about 8% of the new cancer diagnoses in the US. Colorectal cancer is also a leading contributor to cancer deaths, with around 29,000 deaths in men and then around 25,000 deaths in women, again, also accounting for a large proportion of deaths due to cancers. One thing that I didn't remember until earlier is that the 5-year survival probability in those diagnosed with colon cancer is about 63%, which kind of was shockingly low to me for 5-year survival. Obviously, that depends on the stage of diagnosis that's largely contributed to screening practices. One of the good things about colorectal cancer is it's one of the most preventable cancers in terms of having a large portion of modifiable colorectal cancer risk factors. And these are well-established colorectal cancer risk factors, where physical inactivity is a strong risk factor for colorectal cancer, obesity or high BMI, smoking, and dietary factors. Dietary factors include things like a Western dietary pattern or diets high in red or processed meat and diets high in alcohol. So we could be preventing a lot of colorectal cancers by influencing or intervening on these factors. What you'll notice here on this list is that there's not truly environmental risk factors. We have very little literature on environmental risk factors for colon cancer. So you'll notice pollution is not on here, or accessibility to walkable neighborhoods. This type of research has not really come into the field of colorectal cancer epidemiology, and is one place where I think our grant is trying to address that gap. Here's a slide showing the trends in colorectal cancer incidence by different age groups. On the right-hand side, you can see that colorectal cancer diagnoses have been declining in those diagnosed over the age of 50. And so this is a great thing because of prevention efforts, screening efforts, and yeah, I think we've been able to decrease the incidence of colorectal cancer in older individuals by about 50% over the span of since 1975. There's still a lot more that we could prevent by intervening on those modifiable risk factors. On the other hand, there's this alarming increase in early onset colorectal cancer, which is a diagnosis of colorectal cancer before the age of 50. This is a really rapid increase in early onset colorectal cancer that really can't be explained by genetic differences, because genetic differences take much many generations of time to see any changes due to genetics. Of course, there are those modifiable risk factors. We've been having more childhood obesity that could be contributing to these early onset colorectal cancer cases. But the true fact is that we also don't know if there are other environmental explanations for this rise in early onset colorectal cancer. So what about the cancer burden in Kentucky? This is a map generated by the Kentucky Cancer Registry that shows colorectal cancer incidence rates in Kentucky counties from 2013 through 2017. And you can see that there's quite a lot of variability in these colorectal cancer rates across the state of Kentucky. And it's not necessarily clustered in one specific area of Kentucky. It's actually quite spatially heterogeneous across the state. In Kentucky, and that brings upon some interesting questions on why is it so spatially heterogeneous? Are there environmental risk factors that could be different across these counties contributing to higher rates? And I'm sorry, I didn't introduce this, but the higher rates are shown in red and the lower rates of colorectal cancer are shown in that light yellow. Kentucky also is the fourth worst colorectal cancer mortality rates in the United States, with around 20 deaths per 100,000 men and around 14 deaths per 100,000 women in Kentucky. I think the states that are worse than us are West Virginia, Mississippi, and for women, Alaska, and for men, Oklahoma. So we have a lot of opportunities for prevention work in Kentucky is what, in trying to prevent not only colorectal cancer incidence, but of course, preventing death from colorectal cancer. Great, so this is kind of the background. I'll now go into the work that we've been doing where we were trying to get a more granular idea for hotspots in Kentucky beyond this county level map that you see here. So in order to do this, we reached out to the Kentucky Cancer Registry and obtained data for all of the primary cases of cancer diagnosed between 1995 through 2018. And within the Kentucky Cancer Registry, there are about 57,000 colorectal cancer cases in both men and women total. It's actually a really great state registry because of our participation in CIEHS, which is a federal program that where we get a lot of really good detailed information on the diagnoses. But we also get information on patient demographics like their sex, age at diagnosis, and race, as well as tobacco use, family history of colorectal cancer, marital status, and health insurance information. We also know if the individual has died or not, and if they have died, their causes of death. We get good diagnosis data on tumor grade, nodal involvement stage, and metastases sites, as well as some information about treatment modalities. But what's really cool about the cancer registry is that we have geocoded addresses of their home when they were diagnosed. And that really opens up a lot of opportunities to study environmental risk factors. So everyone's address has been geocoded or given, an XY latitude longitude coordinate that allows us to map them to existing databases of environmental risk factors. Okay, so we're supposed to be identifying hotspots. How did we do that? Utilizing the Kentucky Cancer Registry data, where we were able to calculate age standardized cancer rates from 1995 through 2018 for 1,109 Kentucky census tracts. Census tracts are defined by the census every 10 years, and on average, there's about 4,000 people that live in each census tract. That's how they define it based off of the population size within a geographic area. That's the census tract. So with the Kentucky Cancer Registry data, we were able to get the number of cases in each of the Kentucky census tracts. That was the numerator of our age standardized rate. And then the denominator was the census tract population size from 2018. And then we were able to standardize this to sex-specific, the Kentucky's age distribution for both men and for women. So basically, all the differences that you will see geographically are not due to age. That's what the process of standardization does. It makes them have equal age distributions. That was our first step, was calculating these age standardized rates for colorectal cancer. We then used a geospatial statistic called the Geddes or GI star statistic to help us identify these areas of high cancer incidence after accounting for age. We then utilized the American Community Survey, which is a survey conducted by the US Census Bureau every year since 2005 that goes into communities and goes to a sample of homes and asks about social, demographic, economic, and housing information. And then we use the CDC's Places database to learn about the lifestyle characteristics of these neighborhoods. So here is a map that was created by Dr. Matt Ruther and Johnny Newton showing the colorectal cancer hotspots for men. The areas that are in dark red are these hotspots that we have the most confidence in, and then this orangish color shows also areas where we are pretty confident that this is a hotspot area. So if you look at this map of Kentucky, you'll notice that there are plenty of hotspots, strong hotspots in Louisville, but it's not only in Louisville. We also have a hotspot in Newcastle and Bethlehem between here and Covington, as well as hotspots in Covington and Newport, and a few areas over in eastern Kentucky like Warfield and Inez. And then over on the western part of Kentucky, we have a hotspot in Owensboro, Hopkinsville, and Paducah. Total, I think there's about like 74 census tract hotspots that we are rather confident that they are a hotspot. The distribution of colorectal cancer hotspots for female colorectal cancer hotspots is slightly different, but we still see quite a lot of hotspots within Louisville, and now a new cluster within Lexington, but we also see some hotspots in Ashland and southeastern Kentucky as well. And again, there's also about 70 census tract hotspots for female colorectal cancer. So what are these neighborhoods like that we've identified as a hotspot? This is where we use the American Community Survey data to learn about these neighborhoods. And sometimes I might use the words neighborhood and census tract interchangeably. So here's a table that shows the characteristics of hotspot census tracts. So 78 census tracts that were either a male or a female hotspot, followed by the remaining 1,031 census tracts that were not a hotspot. And you can see that about 90% of the census tract hotspots were in urban areas, whereas only about 52% of the non-census tract hotspots were in urban areas. So compared to non-hotspot areas, hotspot areas were in more urban areas. They also had much more racial diversity, with around only around 57% of the population in the hotspots was white, and 34% of the hotspot population were Black, whereas in non-hotspot areas, the racial distribution was predominantly white. Also in these hotspot areas, we had a lower percentage of the population who were married, with only around 27% of these populations being married, as opposed to about half of the populations in the non-hotspot census tracts being married. So I don't go over time. I'm going to just say that the hotspot areas were also more likely to be in non-family homes, have lower education levels, more impoverished with higher percentages of the population below the poverty line, more unemployment, and more people who are uninsured. In terms of other health behaviors, those that lived in the hotspot census tracts had lower screening adherence or lower colorectal cancer screening adherence. They had a greater prevalence of diabetes, smoking, and obesity, as opposed to the non-hotspot census tracts. Now, what about the cancer cases that occurred within these hotspots? This is a table presenting the characteristics of the cases who resided in these neighborhoods. So we have around 3,901 colorectal cancer cases who reside in these hotspot areas. As you might expect, they were more likely to reside in an urban area than those that did not live in a hotspot. They were slightly older. They were more likely to be female. They were more likely to be Black. They were more likely to not be married, and also to be on public health insurance like Medicare or Medicaid. And the colorectal cancer cases that lived in a hotspot, lived in neighborhoods with more poverty, lower colorectal cancer screening prevalence, areas with more physical inactivity, more smokers, and lower education, largely reflecting the previous slide. So I'm going to put I should have put a big asterisk on this slide. We did look at the early onset colorectal cancer hotspots in both men and women. However, I will say with a big caveat that the reason why we didn't pursue this much further is because there are just too few cases to know if these rates are truly stable and reflecting hotspot areas. So I don't want to give too much emphasis on this, but I do think it's interesting to see that the hotspot areas might be more concentrated in more rural areas of Kentucky. Okay, so we've identified the colorectal cancer hotspots. Our next big aim was to figure out area-based environmental correlates of residing in these neighborhoods. And so our students and we were very interested in natural vegetation exposure as well as ambient heavy metal concentrations. So that's what I'll be presenting here today. So one reason why it makes sense to study natural vegetation exposure or greenness is because I showed previously how some of the strongest risk factors for colorectal cancer are physical inactivity and high BMI. Well, there's a lot of literature out there that people who live in greener areas or areas with more natural vegetation are more likely to be physically active and have lower BMI. So it might be very important to look at greenness or exposure to natural vegetation because maybe that contributes to cancer risk reduction behaviors like promoting physical activity and lower BMI. So for this analysis, we utilized 49,450 colorectal cancer cases that were diagnosed between 1995 through 2015. This was just because our greenness exposure data didn't last longer than 2014, so we needed to reduce our sample size to fit our exposure. So our exposure of interest is this natural vegetation at one's residence 5 years prior, up through 5 years prior to the diagnosis year. This is measured through the Normalized Difference Vegetation Index, or NDVI. This data is gathered from satellites orbiting the Earth, and we get estimates of this Normalized Difference Vegetation Index. So essentially, these sensors are sending down infrared and near-infrared light that when chlorophyll is in leaves and is absorbing some of that infrared, it's able to measure vegetation. And this is an example of a map of NDVI from 2010. Obviously, more urban areas like Louisville are less green, and that's denoted by the red, whereas the greener areas are those areas with more vegetation. But even in Eastern Kentucky, there are areas of, we were talking, this kind of correlated exactly with mountaintop removal, but there's also, it's not that all of Eastern Kentucky is entirely green. And I think that's what this map is very clearly showing. It's also showing some waterways here too. Okay. So our outcome for this analysis was whether or not the colorectal cancer case resided in a colorectal cancer hotspot. We used logistic regression to adjust for individual level covariates like age, sex, race, health insurance status, family history of colon cancer, marital status, and tobacco use. Because the cancer registry does not collect socioeconomic markers or weight or BMI or physical activity, that's why we decided to use these neighborhood level characteristics to help us adjust for potential differences in SES, obesity, and physical activity. And then we stratified by urban and rural areas. Okay, so here's some of the descriptive results, just describing who lives in greener areas in Kentucky, in both rural Kentucky and in urban Kentucky. So colorectal cancer cases that lived in greener areas were slightly younger, with an average age of around 66 years old. In the most green areas, that's quartile 4, as opposed to those that lived in the least green area, the average age was around 69 years old. The cases that lived in the greener areas were also more likely to be male than those that lived in the less green areas. They were also much more likely to be white and have a family history of colorectal cancer, and were more likely to be married in both the rural cases as well as the urban cases. The whole SES relationship between SES and greenness is kind of the opposite in rural areas than in urban areas. So the rural colorectal cancer cases that lived in greener areas had lower neighborhood socioeconomic markers, so more poverty and lower median house values. Whereas the colorectal cancer cases that lived in urban areas and lived in greener neighborhoods had higher neighborhood SES markers. They also had less physical inactivity, lower obesity, and higher rates of colorectal cancer screening. So utilizing logistic regression, we calculated odds ratios and 95% confidence intervals for a standard deviation increase in greenness. On the far left side, this is our study population overall. I'm presenting this figure is showing multiple models, so we kind of did different tiers of adjustment. And when we adjusted for the full adjustment, that's model 4 or M4, we observed that for a standard deviation increase in NDVI, it was associated with much lower odds of residing in a colorectal cancer hotspot. And that was there, regardless of whether or not you lived in an urban or a rural area, there appeared to be some benefit of having higher natural vegetation exposure and lower odds of residing in a colorectal cancer hotspot. However, sorry, I didn't really introduce this slide. The y-axis is it goes from 0 to infinity, where this line 1 represents no association between natural vegetation and odds of residing in a hotspot. You'll notice that all these point estimates and 95% confidence intervals do not cross that null value of 1. So this is really highlighting that higher exposure to natural vegetation was associated with much lower odds of residing in a hotspot. We then are now focusing on our heavy metal exposures. So we were able to actually use a fuller population of 56,283 colorectal cancer cases diagnosed from 1995 through 2018. We obtained our ambient heavy metal concentrations from the US EPA's National Air Toxic Assessment, or NATA, that estimates hazardous air pollutants for all census tracts in the United States for multiple years since like 1992. So we were interested in cadmium, arsenic, and nickel and chromium, all of which are the WHO's International Agency for Research on Cancer, IARC's carcinogens. The IARC has identified these as carcinogens. Our outcome here again is whether or not the case resides in a colorectal cancer hotspot. And again, we use logistic regression to adjust for both individual and neighborhood level characteristic, and we stratified by urban and rural areas. Here is showing that we found for most of the heavy metals that higher ambient concentrations of cadmium, arsenic, and nickel were associated with higher odds of residing in one of these hotspots. Even after adjustments for both individual and neighborhood level, we finally got to arsenic. But we didn't really see as strong of results for chromium. Is someone asking a question or am I talking? Okay, it's okay. Okay, cool. So yeah, these were exciting. These are fresh results. And I'm excited that we've got to them. I think, yeah, we similarly, we were nervous that with a lot of the hotspots being in urban areas, that maybe these results were purely just differences in urban and rural. So that's why we restricted to just those cases residing in urban areas, and found the same idea. Even within people that live in urban areas, that higher levels of ambient cadmium, arsenic, and nickel were associated with higher odds of being in these hotspot neighborhoods. So I think this is really exciting. It points to that there might actually be a role of the environment in colorectal cancer epidemiology. I think it actually opened up more questions than answered any questions. And we are still continuing to analyze additional hazardous air pollutants. The US EPA measures about 180 air pollutants every year, and we're only presenting 4 of those, so there could be a lot more. I think these 3 that we've identified might be important to put in a future grant proposal, as well as vegetation exposure. So that's how we're thinking about it as we move forward. I think we can extend a lot of this work to study cancer survival. It's actually probably a more appropriate database for cancer survival than it is for cancer incidence, which is not actually the research question we could answer here. We've done a lot of work, analogous work with breast cancer. If you're interested, it's not as strong for breast cancer as it is for colon cancer, but we're still seeing something with cadmium there. And yeah, I'm really excited to use this for pilot data. I think it's also helpful in identifying neighborhoods, even within Louisville, that we might need to think about in terms of cancer prevention. So I think there's many ways to potentially use this work. Yeah, and with that, I'd really like to acknowledge Dr. Tyler Ellis, Dr. Matt Ruther, Chris States, and Aruni Bhatnagar for yeah, this is a team effort, and we've been utilizing input from all of these great investigators. This work really would not be possible without Felicia, Johnny, and Maddie. They were really the students that led the analyses behind all of this, and we were just there to guide. Also like to thank the School of Public Health administrators and the School of Medicine administrators, as well as the Kentucky Cancer Registry personnel, and most importantly, the funds from this pilot award that gave us the time and money to do this. So with that, I'm happy to answer any questions. Sorry if I went over.